Then Maxwell has joined us, and Dr. Nemiroff is present, as well as Olga Rodriguez. Thank you.
This is Brittany Nichols. I think I missed my roll call as well.
Thank you, Brittany.
And Luann, this is Dr. Chapa. I wasn't sure if you heard me either.
Yes, I got you. Thank you, Dr. Chapa.
Thank you so much.
All right, thank you, everyone. And so we'll move next to the next item on the agenda, the approval of the executive committee minutes for our last meeting on February 19th, 2024. Is there any discussion?
Move to approve.
Second.
Motion for approval and a second. Any dissenting voices? Everyone in agreement, say aye.
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 All right. And
Aye.
executive committee minutes from February 19th are approved. And with that, we'll move to item 3 on the agenda. With that, I'm going to hand off to Dr. Lakey, who's going to lead us through this.
Thanks, Jeffrey. And I'm going to hand off very quickly to Nagla. But before I do that, again, a heartfelt thank you to Nagla and Michelle and the team for doing the hard work to get the what we're calling the new and emerging child mental health researchers initiative moving forward. They have put out the request for proposals. They have developed the interface, that our researchers or applicants will use. We have started the meetings with the reviewers. Happy with the reviewers. They're people nationwide of tremendous stature that will be part of this review committee. And again, we had a good. I'll let Nagla go through the numbers, but we're pleased with the number of people that applied throughout the mental health care consortium. And as we've noted, we've tried to really focus this on how do we improve the mental health system here in the state of Texas. Again, appreciative to HHSC. A lot of their staff put together a document that was used as guidance on issues that they think are very important for us to be smarter about to provide better care for kids throughout the state of Texas. And so pleased that we'll be using basically $6 million to invest in young junior investigators and get them on the pathway so that they'll be able to be successful academic mental health professionals here in the state of Texas and be people that hopefully sometime will be sitting in your chairs. So with that, Nagla, you have the details about how things are going. Let me turn it over to you to share that information.
Thank you, Dr. Lakey. I'm going to just go through a verbal update. First, I'll go through the status of where we are, and then talk a little bit about our review committee and where they are, and then submissions so far that we've had on the pre-application, and then talk about where we are on the timeline. So, so far, we've completed the pre-application submission process. The deadline was last Thursday, and we have been in communication with all the HRIs throughout that process and answering any questions that had come in. And so we are right now working on reviewing those submissions and figuring out which ones we will be inviting to do a full application. So the next thing is the recruitment of the external reviewers. We have recruited the full review committee, and we're currently working on getting all their paperwork set up. So they're in our system, have access to the grant software, and we have been scheduling orientation meetings. We had our first one last Friday, and we continue to have them to make sure that they're feeling comfortable with the process. The other thing is setting up all the reviewers completing the testing of the full application grant software. So the grant software has been set up for both the pre-application, which we did all the pre-application through that. But now with the full application set up. We're just doing some testing, making sure that everything is working well and that as we go through that process that we don't have as many hiccups. And then we are finalizing again the review of the pre-applications. So our review committee has 14 folks on there. As Dr. Lakey said, 11 of them are independent reviewers from outside of Texas, and they're really from all over the US, from the West Coast, East Coast, North, South, and they're folks who are very much entrenched in their states in positions of either chairs or reviewers on other committees as well, and areas of child psychiatry and some perinatal psychiatry as well. Then we also have 3 other reviewers from within Texas, and those have mental health, nonprofit, LMHA, and state mental health program expertise. As far as the status of who submitted for the pre-application, we had a total of 52 submissions. Of those, 5 were postdoctoral fellow and trainee grants. 13 were research career development grants, and 34 were research project grants. And we had every single HRI except one have submissions, and the submissions varied from 2 to 9. Now we did ask folks to submit more than the 6 per HRI because we wanted to make sure that we had sufficient submissions and that they also were of all the 3 different types of grants. As far as the timeline, okay. So as far as the timeline, we, as I said, had the pre-application process deadline was last Thursday. We are right now working with the HRIs, the chairs of psychiatrists, to review and rank all the submissions and make sure they were all, you know, one of the requirements, what they had to talk and coordinate with the chairs. So we're making sure that that happened and that those are the ones that would represent each HRI. As we go through them, then we're going to go ahead and invite them for submission of a full application. The full application will open up April the 2nd. And then the application deadline after that is going to be May the 9th. The review process will start as soon as any application is fully submitted. And we are hoping then to complete the group review with the reviewers. So they go through an independent, you know, a one-on-one review of each application, but then we are going to provide a group review process. And this is to make sure that there's consensus and make sure also that we have representation from all over Texas. Once that group review is completed, we plan to bring the list of all the finalists to the executive committee, which the July 15th meeting, and have that voted on. We're not going to vote on each individual applicant. We'll vote on the full finalist and go ahead and notify them of their receipt of the grant. This is all I have as the update, but if anybody has any questions.
I do actually, Nagla. First, let me just say, you and Lachelle have done a fabulous job in putting this together. It really is the kind of program that NIH has 10 people working on. And the fact that you all have been able to do this is remarkable. I had a question about the step between the chair approval of the project and then the invitation for full application, and who exactly is looking at that and making that decision.
So we are just double checking the eligibility of each applicant. So we're just looking to make sure they meet the minimum eligibility criteria that we established for this grant. Most likely all of them have, but we're going to be reviewing those. If somebody does not meet that, we will be reaching out to also the chair of psychiatrists. We're not going to just exclude anybody who is one of the top 6 of any HRI without having a discussion and make sure that there's awareness of whether they did not meet the eligibility criteria or not. And then once we've basically came up with these are the top 6, which again, the chairs of psychiatry are the ones who identify their top 6. So it's not that we're going to identify different ones in any way or exclude anyone. And then we will just reach out to the candidates and let them know that they have access to the full application. Does that answer the question, Dr. Nemo?
Absolutely. Thank you.
You're welcome. Any other questions?
Seeing no other questions, again, thank you to everybody for working with your faculty to get submissions. We're pleased with the number of submissions that we have received. Again, thank you again to Denag and Lachelle for doing the groundwork to put the infrastructure in place to do this. We're trying to do due diligence to make sure that we work very closely with the chairs of psychiatry, that we understand your priorities of who you want. And we will, again, make sure that we have quality applicants. You know, the entities that we fund will be quality applicants, and that we will ensure that we that we work fairly across our institutions, so that we can build all of our institutions across the state of Texas. And so we're trying to be very careful as we do this. But again, this is, as I told some of the reviewers last Friday when I was part of their meeting, this is the first time we've done this. There's probably something that's not going to go exactly right. And so we ask for your grace as we put this together, but we've tried to work very closely with CIPRIT and other funding entities in the state of Texas to learn from them best practices and make sure that we don't step into any quagmires, any problems that they have stepped in before. And so again, we're trying to be very diligent as we move this forward. But again, thank you all for your help, and look forward to that July meeting when we can share with you the slate of proposals that we will recommend to be funded. So thank you. And Jeffrey, I'll turn it back over to you.
Okay, thank you, David. With that, we'll move on to the next item on the agenda, presentation of data and the update on statewide expansion of TChat. And I believe, Lachelle, you're going to lead that discussion.
I'll be doing that, Dr. Newport.
Okay.
Thank you all. I'm going to share my screen. So we have some school data as of the end of January to share this month, as well as a little bit of referral and services data as of February. So you can see here, as of January 31st, we are active in just over 66% of all schools. That represents 71% of the student population in Texas. This month, 9 HRIs added at least 1 school district. You can see that we have still 650 schools in a planned status. In the coming months, we'd really like to see those moved, hopefully to a pending status, but if not, to an unresponsive or declined status. UT Austin, UT Southwestern, and UT Tyler all have planned implementation dates for the upcoming months. We saw by ESC, we saw increases in active schools in half of our ESCs this month. That's ESCs 1, 2, 6, 7, 8, 10, 12, 13, 18, and 20. You can see here that the growth of schools and our population continue to increase. The top reason that schools decline continues to be that they have existing mental health providers. Here's some referral data. So you can see in February, we had an increase in referrals from January. There's a 35% increase. Compared to last February, that is a 42% increase in referrals. In trait, we've referred almost 55,000. We received almost 55,000 referrals and enrolled 34,000 students. Of those we've been unable to refer, the vast majority have been due to no response. Students served and session counts. You can see in January, we had our highest number of sessions ever. There's a decrease in February, about 17% compared to January, but you can see that we're still very high in terms of number of sessions that we provided, and that is a 71% increase from last February. Students served also increased 44% from the previous February. Any questions about this?
Those are great numbers. It's just amazing how it just keeps going up and up. Good job, everyone.
It is a pretty impressive volume now. And so again, congratulations to all of our departments of psychiatry and all your members, your faculty members and staff that are doing this work. It's become very busy. And so again, a heartfelt thank you to all of you for that work.
Any additional discussion before we move on? Okay, next on the agenda, we have a couple of action items, TChat action items that we're going to require review and approval by the executive committee. And I believe Rachel is going to be presenting this information.
Yes, me again. I believe we're starting with TChat 2.0. Just wanted to pull this up. This is at a glance of what we shared last month. This is our new strategic direction for the TChat program, really to enable us to integrate some of our pilot projects statewide and standardize some operations in other areas. Does anybody have any questions before we vote?
I have a question can we clarify a little bit the non-urgent, short-term, intermediate care? I think there are different views on maybe what that means. And we know that it's not emergent, but in the conceptualization originally of this program, it was to address fairly urgent needs of kiddos with mental health distress. And so I just wanted to have at least some discussion about this verbiage so that we're all on the same page about it.
Sarah, I think what you said is correct. And Laurel, if you want to jump in, that's fine. But I think the reason it is written that way is that we're not the emergency room. So if a child is frankly suicidal right now, that they need to use a different way. But there are a lot of kids that are not emergent, but still need to get services relatively quickly. And that is a role that we play. We're not there to be the long-term solution for kids. You guys work from the very beginning to get people into longer-term care in the community. But you were initially kind of short-term, but because of experience that you all have had, because of the challenges sometimes of handing children off to another provider in the community, we saw the necessity to be more in that intermediate time period. So short term, we were initially striving for 5 visits. Now with the experience, because of the challenge of handing children off to a long-term provider, it's been necessary to go 10, 15 sometimes, but still trying to be the majority of the cases being in that shorter term period.
Well, Dr. Leakey, my question is more about the urgent language, I think, or the non-urgent. I've heard confusion on meetings. I totally agree that we're non-emergent. But we had conversations at the beginning that, we weren't emergent, but we are for kiddos who have, current pressing, non-emergent, but somewhat urgent needs to have their mental health symptoms addressed. And so I would just feel more comfortable if we put non-emergent, because I think that non-urgent, I've heard confusion on meetings where people were like, well, are we supposed to be serving kids with that high a level of symptoms if we're non-urgent? And I think it causes some confusion because nobody exactly knows what that means. I think we do know what non-emergent means, that we don't need to send them immediately to the hospital.
Okay. Any other thoughts on that?
I agree, but I'm an emergency, psychiatrist. So, and I do think it'd be important to make sure the schools understand what those definitions are, right? But yeah, I agree with the non-emergent, but yes to urgent.
Okay. Laurel, what are your thoughts of changing urgent to emergent? So it'd be non-emergent short term?
I don't think that I have a problem with it. I do think that has been to Dr. Wakefield's point, that the essential conversation is the space that we want to be in is being able to see the kid quickly. So we talk about, we want to be able to see the kid quickly, but not if they're in a crisis or an emergency state. So our goal is always to schedule the appointment as quickly as possible. And sometimes that can be within just a couple of days. It's also just parent preference too. But if it's truly emergency, they need to go that day or within like 24 hours. We really want the schools to make sure they're just activating their processes they already have available to them for things that are crisis or emergency. So I don't personally have a problem with that.
And our teams have been trained to really identify those that are emergent and get them to the right place at the right time for the right care.
Okay. So Jeffrey, maybe a friendly amendment to change the word urgent to emergent. So it's non-emergent short-term immediate care.
Okay.
And with that, I think
such a motion.
What's that?
I am making the motion.
Okay.
What is the motion specifically?
To change non-urgent to emergent?
Non-emergent, I believe. Simply to change
Right.
urgent to emergent.
I second.
And all in favor say aye.
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 All opposed, all opposed say nay. And the motion is approved.
And then Jeffrey, I think we need to have then a formal approval of this version then of TChat 2.0.
Okay, any discussion regarding formal approval of this version of TChat 2.0?
I move to approve with that, this version, or with the change from urgent to emergent.
Okay, thank you. Do I hear a second?
I will second.
All in favor say aye.
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 All opposed say nay. And that motion is approved as well. And now we move to TChat policy governance.
That is me as well. Let me share my screen again. So again, last month, we went over this proposed new policy that really defines our approach to policy development, review and implementation. So you all should have had a chance to review this document in its entirety. Does anybody have any questions?
Move to approve.
We have a motion to approve. Do I hear a second?
Second.
All in favor say aye,
Aye.
and all opposed say nay. The motion to approve the TChat policy governance plan is approved. And now we move on to TChat research participant recruitment.
So again, last month, we shared our draft version of this policy. This is really it just aims to codify previous decisions that were made that ensure that we're not recruiting research subjects through our TChat program. Any questions?
Okay, do I hear a motion?
So moved.
Will second.
Okay, have a motion and a second. All in favor say aye.
Aye.
All opposed say nay. And the motion to approve the TChat research participant recruitment language has been approved. And with that, we'll move on to the update from the Data Governance Committee. I believe that's Dr. Pliska.
The data governance met and approved the submission to a journal of an article by Eric Storch and his colleagues looking at the stepped care program. And actually, Eric is item G on the agenda, so I will defer any discussion of that, and you can hear it straight from him. The management committee also, data governance management committee also reviewed a research proposal from one of the HRIs that was sent back with suggestions for revision and edits. And of course, if the HRI then can resubmit that to us, so it was neither approved nor disapproved, we're awaiting those edits. Otherwise, that's all I have to report.
Any questions or comments or further discussion?
And either Eric or myself can send you a copy of the manuscript if you want to take a look at it yourself.
All right, thank you. And we'll move on. Dr. Trivedi will be presenting and providing an update on the implementation of YAM.
Thank you very much, Jeff, and thank you, Dr. Leakey and everyone. So the Youth Aware of Mental Health Project, just a little bit of editorial. I am thrilled with what the schools have been doing with us and with the HRIs, and I cannot thank all the leadership of all the HRIs for actually crossing our expectations. And I'll talk a little about it. I have 5-7 minutes and leave a few minutes for questions. Next slide. So we have been, obviously, our major task is to make sure that each of the HRIs have trained, certified YAM deliverers, and they have basically connections with the schools. So you can see we as a team at the hub have been profoundly active. We keep on having a lot of training sessions, and you can see it. It's right from June 2021 to March 2024. We've had so many of these training sessions, and they have been really fantastic. And you've heard about this from other trainees who have been certified, so I'm not going to belabor the idea, but I think we now have a very well-trained staff across all HRIs. And obviously, as we when it was started, it had was initial phases. So therefore, there were a lot of people who were at the senior level who were trained who were not going to have the time to deliver. So now we keep on having additional training sessions like the one we had in March. But the good news is now there isn't an HRI that is not doesn't have enough trained staff. There are 3 or 4 HRIs that are not yet participating, and I'm hoping we will be able to engage with all the four HRIs that are not participating, because I think the impact, I'll give you examples. So I don't know, next slide. We obviously, once there are trained staff at each of the HRIs, the biggest task is to engage the school. And in some ways, it is kind of a learning process. So I'll give you my personal example. I just visited a school district. I talked to the principal for 15 minutes and he wants it. When I started doing it, it took me 3 meetings before they would agree. So I think we now have a very well-oiled machine about this, where we create all the materials, all the training sessions. We also at the hub level, Toby Fuller, my compadre on this, and us, we are available to meet with any of the school districts. We still have calls and Zoom calls where the hub team meets with the school leadership. But the bottom line is we have created a structure where everybody in the system, one of the issues with this kind of school activity is to ensure that everybody, all the stakeholders in the school, sort of leadership as well as the stakeholders are all on board. And we have created that structure. So actually we are now welcome to the same school year after year. And that's what we have done. Next slide. As you can see, we have MOUs signed. So this is just engaging with the school leadership and stakeholders is wonderful, essential, and irreplaceable, but that's not the substitute for then having a formal memorandum of understanding between the HRI and the school district. And as you can see, this is the list of all the MOUs done. Obviously, it depends a little bit on the size of the school districts, and we at UT Southwestern have been doing this for a long time. We try to ensure that we go to larger school districts when possible. That way, we can have a bigger impact on students. Early HRIs that are beginning the process have to start with smaller districts. Remember, as you all should know, you all know already because we've heard this on previous meetings, that ultimately every stakeholder has a big say, and therefore you want to make sure all the stakeholders are involved. And therefore a smaller school district for a starting HRI is more essential. When we go to larger school districts like the Fort Worth or Dallas or Irving, then we have the experience, so therefore we are able to do it fewer school districts. So the number of school districts will keep on expanding, but as you can see, we are now offering this program to over 1.25 million students in the state. And as you can imagine, and you saw the numbers with TChat, I'll show you next slide. We are now reaching students and student classes in large numbers. So we have exceeded our goals. We have reached already 30,000 students. It amounts to over 500,000 hours of real impact with students. Our goal by the end of this school year is 35,000. We've reached we'll be reaching 2,000 student classes in the state. That's huge. And as you can see, all the HRIs are really at the peak of their game. They are expanding and more requests are coming. We're getting to a point where we'll need to talk about how to really satisfy all the requests we are getting, because it requires staffing to go to these places and booklets and all that, and we can talk about that. But I think all in all, I have to step back. I have to tell you guys, all of you, that I could not have imagined the success we've already had. If you had waterboarded me, I would have said it's going to be harder, but this has been a wonderful success. So I appreciate everybody. All the HRIs are actually excited about it. And so thank you all for everybody. We couldn't do this without HRI really getting into the work. Next slide. Just a quick example of what we are hearing from students, and obviously this is not comprehensive, but just examples, and I'll read 2 or 3, but you can read the rest. I really liked role-playing different situations. I learned to find solutions in stressful situations as well as depression situations. The booklets were very helpful. I liked hearing different opinions from everyone, etc. All this work so far, and we use this, we just got a SAMHSA grant to be able to now get real feedback, focus groups, and evaluations from parents as well as adults and leaders in schools. And so next 2-3 months, we'll do that work, and I'll bring data from that to really give you all a sense of what the parents and adults in these kids' lives are seeing, the impact of this program. Next slide. We also have launched, as we had promised before, a wellness ambassador program. So this is really, in addition to doing YAM with students, we want the each school to then have a wellness ambassador. The way to roughly think of them as, they are like coaches. They're like my son's cross-country coach. He had a bigger impact. He was a valedictorian for his school, and when he gave his speech, he actually thanked his cross-country coach. That's what we want for wellness ambassadors for schools for wellness. And so we have developed, with the help of a national school advisory board, we have created a wellness ambassador program that is now that has been launched, and it has 4 goals. And in the interest of time, I won't read all of them, but really we want to follow up to ensure that the resources are meeting the students' and families' needs. And this is really because YAM really serves as for the whole classroom, but then those kids, then they need some adult in their school to give them guidance, advice on what is it they need to do. That wellness ambassador really comes into play. And I think we're finding it already, initial stages, quite invaluable. Next slide. So I'm going to stop here, Jeff and Dr. Lakey and others, to open up for questions. I didn't want to overstep my time, but I think all in all, thank you all for supporting this program. I'm very excited.
Dr. Trivedi, if I may jump in, first, thank you for the work, and thank you again to everyone for the work that's taking place. On the numbers, I'm trying to think through some of the numbers that you presented. It looks like there's been about 30,000 kids that have been in classes, but then you had the 1 million number there, and on the slide it said million people served. It sounds like that's really 1 million kids that are in a school system that has an MOU in place that had the potential of taking a class.
That have access to it, yes. And if we expand it, we can have programs for all of them.
So,
yeah.
So there's 1 million kids that are in a school system that if there were enough people that you could have a class there. And so I think we need to kind of think through that number of how we use that number, because I think it may give a little bit of a false assumption there, because we're nowhere near 1 million kids that have been in a class. And then that leads then to, I guess, kind of a strategic discussion we need to have at some point is what do we do next session? Is the plan to go to additional schools, or is it to better reach the million or so that an they're in a school that an MOU is already in place? And at some point in the not too distant future, we're going to have to figure out, each of the HRIs is going to need to figure out what their work plan will be for the next biennium, and how many additional people they think that they will need, and cost that out so that we can put the right numbers into a budget for the next session. Am I thinking about that correctly?
Absolutely. I think that it is above my pay grade. It is for this group and the leadership to decide how big of a footprint you want, because exactly the point. I think that these schools that have already done an MOU is, do we reach that whole population? Do we expand on it, et cetera, is something that the larger group will have to be impacting. Absolutely. I think the way to think about it is, when we started, as you know, remember, Dr. Lakey, there was some question whether schools will like it, will take it, et cetera. I think the experience has told us that they like it and they want it. Now the question is going to be, what is the footprint this group is intending to have?
So it may be strategically smart to better saturate that group that we already have an MOU in place, that the school is already amenable to this program, versus reaching out to a variety of other schools and doing the paperwork. It always takes more time than you think, getting the MOUs in place, et cetera.
With one caveat, I think that some of the HRIs, including some of us, for example, even at our UT Southwestern, we've been doing this for 7 years. We do want to keep open the option of allowing the 2 or 3 big school districts in any HRI to become part of this, because they come in later as opposed to earlier. So that's the question. Like if you are in Austin, then the Travis County, the Travis ISD may take longer, or same thing in Houston, everywhere. So that is the only caveat, but otherwise you are absolutely on the right. Yeah.
And if I remember this correctly, we tried to be careful with working with the local mental health authority, which was doing mental health first aid in certain schools, to avoid some confusion. And so I think as we think through what our plan is, having the HRIs talk to the local mental health authorities so that there isn't an overlap there or confusion as we put together each of the basically 12 plans for the next step of this type of preventative services, correct?
And we have absolutely been working very closely with all the LMHAs in each of the HRIs, as well as the educational service centers, ESCs, because they also impact the same school districts, and ensuring that we are not double sort of making it complicated. Yeah.
Yeah, and Dr. Lakey, I would agree with that, I've not heard any rumblings about challenges. I think they've done Dr. Trivedi has done a great job,
Okay.
With the coordination.
I just want to make sure we're continuing to be coordinated and don't overlap. So thanks, Sonia. Thanks. Yeah, you've been very, very helpful to make sure that we do this correctly. Yeah.
Yeah, I appreciate that, Dr. Lakey, and I have not heard rumblings either.
Good.
So that tells me that coordination is happening well.
Okay, good. And then I guess another question on the numbers, Dr. Trivedi. That million number is full, is a K through 12
correct
age group, but
No,
we're focused on certain grades, right?
It's middle school and high school, so the middle school will get to that stage very soon, is obvious.
Okay.
Not the K through 5 to the middle school.
Okay. So that's just kind of, again, I just want us to think through some of these numbers together before I'm giving it to the legislature to make sure that we feel very confident with the numbers. And so that's why I wanted you to present today, to hear the work. And again, that's not being dismissive of the great work you're doing. I just want to be very careful with the numbers to not overstate what we're doing. As we also make the case of what is a reasonable next step for the next session. And so what I think our team is going to need from each of the HRIs is for you to look critically at your current program and think through what is the logical next step over the next biennium. What's that going to cost? And then let Dr. Trivedi, but also let Lachelle and my team know that so that we can continue to start and build the budget for the next biennium.
And we have a follow-up call with your team, Dr. Lakey, to start thinking exactly that. But since I have the little bit of space, I have to say this. I work very closely with the Tarrant County MHMR. And Sonia, they even still feels very proud of all that you have done. So you.
Thank you.
They keep on reminding me that you are one of them. So thank you for doing all that you have done for all these years. So
thank you, Dr. Trivedi. I appreciate that.
So all of us have homework related to this program. Again, great work. It's good to be associated with it. Got to think through what the next step is, and need you all to think through that and start cranking the numbers so that we can be very solid on what those numbers will be, and what's realistic, not what's hopeful, but what is realistic for you for the next phase of YAM in your jurisdiction. And again, it makes sense to me that if you have MOUs in place and are only partially there, that that may be a good opportunity to strategically for the next session.
And a little plea for the HRIs that are not doing it to think about it. They still don't want to obviously be respected, but maybe we're thinking.
Yeah, that's a good point. So if there's other HRIs that bowed out earlier, but think that now is an appropriate time for you to be on the upstream part of this, on the preventive side, let us know, and we can figure out how we can support that.
Thank you so much. Thank you for the opportunity, Dr. Newport and Dr. Lakey.
Thank you.
Okay, thank you, everyone. And the next item on the agenda, updates from each participating HRI on the number of child and adolescent psychiatry fellowship slots were filled in the most recent match. And with that, Luann's going to step us through.
Okay, I thought the best way to do this was just to call out each of the HRIs. And so you can tell us how many positions were filled. And I will start with Texas A&M University.
We filled one position.
Okay, University of North Texas.
2 of 2.
Baylor College of Medicine.
8 of 8.
Texas Tech Lubbock.
2 of 2.
Texas Tech El Paso.
We expanded to 4 in each class this year, and we filled all 4. I'm so happy.
Congratulations. University of Texas Dell Medical School.
5 of 5.
University of Texas San Antonio.
So officially, we have filled 4 of 6. We have a 5th that we should be filling very soon. It's just not official. And so that would leave us with 1 vacancy.
Thank you. University of Texas Rio Grande Valley.
Oh, hello.
Go ahead, Dr.
Oh, no, go ahead, Dr. Chapa, sorry.
We don't have the fellowship, but we did fill 5 of 6 because we had one resident coming in.
Thank you. University of Texas, Tyler.
Hi, we filled 2 out of 2. Child, you're just talking about child and adolescent.
Yes.
Yep.
University of Texas, Houston.
We filled 6 out of 6.
University of Texas, Southwestern.
7 out of 7.
And last but not least, University of Texas Medical Branch in Galveston.
2 out of 4.
Well, this is fantastic. Thank you so much.
It really is fantastic, and to have these brand new fellowships fully filling, it is, you know, again, quite impressive. So thank you all for that continued work. It really will have a long-term impact, obviously, for the workforce needs in the state of Texas. And I think the combination of the fellowship and plus the recruitment that you've made to fund TCHAT and CPAN, I'm hearing from folks that we're already seeing a change in the data related to the lack of child and adolescent fellows in the state of Texas. And so this is tremendous work. And so thank you all and congratulations for filling these new fellowship programs.
Well, I want to say in total, that's 43. And if Dr. Olvera gets that 5th one filled, it will be 44, which is really incredible. Thank you.
And to remind folks, before the consortium, there are a total of 26 slots in Texas.
Oh, so I'm sorry. I thought we were just talking about the new match for the new fellows. Did you want us to say for all of our fellows?
No, that's okay. That's for the new match. Yeah.
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 Okay. Because we have
Yeah.
four, but yeah.
Yeah.
Just I didn't want your numbers to look low.
Yeah,
lower.
but no, but for child and adolescent fellows, before the consortium, there were 26 slots in Texas, and it sounds like after this match, we've matched 42 here in the state of Texas, and so that's a tremendous increase. So thank you all.
Hi, David, could I say one more thing about the match? About the fellowship?
Sure, go ahead.
I think one of the reasons we're getting more interest in here at Texas Tech El Paso in child psychiatry is because we used to only have the residents rotate on the inpatient service at the state hospital, which is very, very intense. And so once we started the consortium, we've had our residents rotating as PGY2s on TCHAT and CPAN one-time consults, and they've really enjoyed it. And I think it really gives them a better idea of what child psychiatry is really like. It's not all like huge crisis and suicide attempts. It's much, much more than that. And I think that's one reason that we've been able to generate more interest here. So it's been great.
That's good. You know, another piece of data, and I'll have my team reach out to all of you to gather, is that, you know, if we can get information of where your current graduates are going to go, because what I'm getting the sense of from folks when I talk to individuals is that they're staying here in Texas. And so that's, again, another part of the story that we need to be able to tell the legislature and show them that they invested in training for individuals and they're staying here in Texas. And so I'll ask Luann if you could, following this, send an email out to folks and as best you can, tell us what your current graduating class, what state, what institution that they're going to. That would be very helpful to us. Steve?
Yeah, I was just going to say the CPWE, David Lynch working with the CPWE has been gathering now. We're our focus more on the people who are actually funded by CPWE. But David, if he's on, might have just some a general answer to your question from the data from last year's graduating class.
Good morning. I don't have any numbers right here to present, but
we will be presenting a summary in the upcoming EC meeting on that. Surveyed the training directors about their placements. So we'll be presenting that summary information later. But as best as I remember, it was a very positive signal that folks found a lot of value in the placements, and folks did tend to stay in the state. So, but we'll have some numbers to back that up later.
No, David, that'd be helpful. And I think there's two different components. That there is the general residents and the exposure of CPW, and are we retaining those? And then another question, with the new slots, are the child and adolescent fellows staying in the state of Texas? So the sooner we can gather that information, that would be information that I'd like to include in whatever presentation that I'll be doing probably this summer with the legislature. Thanks.
Okay, thank you, everyone. Next item on the agenda, Dr. Storch will be presenting an update on the status of the Stepped Care Initiative.
All right, very good. Thank you. So if we could move to the next slide. So one of the goals that we hope to accomplish within this sub-project of TCHAP was actually looking at that model of care that was discussed a short while ago, where we're looking at both a short-term and then intermediate-term treatment approach for children with internalizing-based problems, so particularly anxiety, depression, irritability, obsessive-compulsive symptoms. Now, one of the challenges, of course, with existing interventions is that in a number of ways, they've been very disorder-focused. The positive of that is the specificity and the established efficacy of those interventions. The downside is the difficulty in getting clinicians trained up on a number of different specific interventions. And so what the Unified Protocol, originally in adults and then later developed for children and adolescents, has done is it targets kind of underlying mechanisms that are believed associated with a particular set of disorders. So in this case, depression, anxiety, obsessive-compulsive conditions. And so it uses a number of evidence-based components in order to address those problems, including things like exposure therapy, behavioral activation, and cognitive therapeutic approaches. Now, to the right is a table from meta-analysis in adults, which showed pretty meaningful efficacy with an effect size of about 0.75 relative to a variety of control conditions, which include both strong and weak controls being things like wait list, stronger controls being kind of active therapeutic conditions like relaxation therapy. And then these results have been replicated when it's extended down towards children and adolescents, where there's comparatively a smaller evidence base, but still quite a meaningful one in general. Now, at the same time, we wanted to get at these innovations in a variety of other areas, including making sure that we had a more personalized intervention approach, that we're being resource sensitive in terms of providing people with only the amount of intervention that they need, not more, on the other hand, not less, and really kind of connecting our interventions together with a measurement-based care approach so that we're able to titrate treatment based on individual need. And so we took an approach that many others have done, but that we've had some success through NIH-funded work in children with trauma, where we've developed out step care treatment approaches to trauma-focused cognitive behavioral therapy for younger children. And so our model looks the following below with the flow chart, where we have a baseline assessment at session 1, 4 CBT sessions per the Unified Protocol for children and adolescents, at which point there's sort of a treatment planning decision assessment session held, at which point individuals either step down to ongoing case management as deemed appropriate because, as the next slide will show, they either met their goals, or just wish to discontinue. Or they step up. And that step up version really reflects that intermediate level of care where there's an additional 7 sessions at play for a total of 12, at which point there's another assessment to kind of, again, monitor how well they're doing. Theoretically, this type of approach is really sort of what could go on and on, where there's constant evaluations of progress and then intensification or de-intensifying intervention based on individual need. One last point of this is that the decision is very, very collaborative. So the family may be doing great but wish to continue, or more likely, they may not be doing well and then they can say, hey, we want to move on, or we're done, or we found another provider. So again, that collaborative decision-making process is key. Next slide, please. Now, one of our other goals has really been workforce development. And so in this way, we've been really excited that we've had 44 clinicians across a number of HRIs with logos below who have participated in training as well as certification in the Unified Protocol for children and adolescents. Now, the certification process involves an initial training, but then ongoing consultation sessions. And so this is based on a not surprising literature that says that if you train people in something without ongoing consultation, they essentially will never use it, as opposed to being able to use it in action and with kind of expert feedback at play. And so of those 44 that have been trained, we've had 29 achieve certification, and then we're working on additional trainings to be coming up relatively shortly. Next slide, please. And so from an outcome data standpoint, we're really excited about where things sit. So in the lower left, you see the pie chart that shows that about 38% of kids have actually stepped down, meaning that in general, they were either doing well or they've been successful kind of triaging of their case to other referral sources, or there's a patient preference factor that came into play. Now, on the other hand, we had about 37% step up, meaning that there was a collaborative decision that involved them wishing to have additional care at play. About 20% dropped out before that decision point, and then about 6% had a planned termination before that step care decision came into play. So in general, what we're sort of seeing here is really how I view it, interpret at least, is really a successful personalization of care where we were able to, in that resource sensitive manner, sort of say people need this much treatment and they receive that much treatment, or they may have received or needed more care at the same time. Next slide, please. And then as well, when we think about outcome data, we've measured outcomes across a number of different questionnaires, as well as therapist reports. So with the PHQ-A, we ended up seeing an effect up to that mid-treatment point. So again, after a total of 5 sessions of 0.92, and then on anxiety of 0.58. So, medium to large effect sizes across the board. And then when we considered those that stepped up, we actually ended up seeing quite large effects across both of those metrics. Now, the part that I'm also excited about is when you start thinking about the therapist and parent perspective of overall Gestalt improvement, we used the CGI improvement rating. And so we ended up seeing about 58% of kids after a small handful of sessions were considered much or very much improved. And that increased over time for those that stepped up to about 65%. What's notable about that is that those that stepped up were presumably a bit more of a severe presentation at play, because otherwise they sort of would have completed their treatment after 5 sessions. So the fact that we're seeing about 2/3 of our sample do very well afterwards within kind of naturalistic clinical care is really very optimistic. And then, of course, if you consider that a number of those other individuals, about 24, 25%, also had some sort of minimal improvement, is also very favorable related to overall outcomes. Next slide. So thoughts about where do we go from here? I think the biggest one is trying to continue to develop this. And so we're right now getting in the works a number of different additional trainings scheduled for this summer when, as one of the earlier slides showed from earlier in the talk today, that June-July period is really a slower period because, of course, schools are out. So we're trying to make the most of getting people onboarded and then being able to start on consultations. There's also, of course, the possibility, if the Executive Council believed appropriate, to think about other areas where step care approach could be useful to thinking about short-term and intermediate-term care. I alluded to one that was focused on TFCBT, where we've had a series of NIH-funded grants, both developing out a parent-led approach to a step care version of this that we then further validated in an R01. And so that's just one example of an area that could come into play. Of course, there are many others too. And so I think the idea is, how do we think again about a resource-sensitive, effective intervention, measurement-based care model of psychotherapeutic care? And then the last point that is one I just sort of enjoy thinking about is really how do we try to have harmonization of therapists as well as fidelity of the intervention models that come into play. And so in psychotherapy, there are certainly these non-specific factors that are so critical, but we also know that certain kind of intervention components are really core. And so the question is, how do we make sure that people are doing those components in a similar fashion with high fidelity, as well as with high fidelity in order to maximize outcomes of our kids? All right, I think that does it. Thanks. Yeah, any questions I can try to answer?
Well, Eric, I think the results are impressive. I have a lot of questions that I'd like to ask you offline that relate to, there's been a lot of controversy about the unified approach relative to it applying to individuals with anxiety disorders, depression, trauma, etc. And so what would be of interest would be to know what the baseline diagnoses were and how they individually responded to the unified treatment, and whether there have been any comparators in those populations, for example, to trauma-focused CBT versus the unified approach or cognitive behavior therapy for depression. I'm sure Madhukar would be interested as well, but the initial results look really exciting.
Yeah. Thank you for that. And actually, I'm not aware of any controversy in the kid version. So if there's something I should know, please by all means send it my way. So a couple points. One is unified protocol is not appropriate for trauma as a primary condition, so shouldn't be used there, and we haven't used it in that primary diagnosis or secondary diagnosis for this. So we wouldn't have any kids that had PTSD as their primary concern within these data represented. Second is that because this is just TCHAT, for this, of course, it's not a research study, so we're just trying to do sort of a QI piece. And then we do have primary diagnoses. My sense is that we saw a lot of kids with, we saw a lot of kids with anxiety or sort of kind of mood dysregulation based conditions. One of the things that I will say when you analyze the child version of the unified protocol is I think a lot of the studies tend to focus more on sort of that group of kids as opposed to kids that are much more depressed, where I think a behavior activation approach can be a very effective approach for those kids. Maybe a third point or fourth or whatever number I'm on, is that notably across all these kids that were treated, it was naturalistic care. So if there was a child on an antidepressant, for example, that was great, and they would have ongoing consultation with their physician in terms of whatever made sense. So of course, very different than a controlled trial at play too. But a few thoughts in response, and of course, very happy to come back.
Thank you.
Yeah, of course. Yeah, any other questions or?
Okay, thank you, Eric. And with no other discussion on that point, we'll move on to the next item on the agenda. Dr. Wakefield will be providing an update on PeriPan implementation and statewide rollout.
If you don't mind, I just have a quick correction for the match. For UT Southwestern, we actually matched 13 out of 13. So we have 9 out of 9 in our regular child psychiatry fellowship, and then 4 out of 4 in our triple board, psych, peds, and child psychiatry. Thank you.
Thank you, Dr. Ibrahim. Yeah, that the new triple board is an exciting program. So congratulations on fully matching it.
Thanks.
And nationally, UT Southwestern is becoming one of the bigger programs in the country, right?
Yeah, I think the triple board is the biggest in the country.
Well, that's very exciting. Congratulations on that new program. And I was going to say, Dr. Storch, thank you so much for presenting that stepped care model. I think those of us who provide this, provide care to kiddos and hopefully to everyone know that this is the way to the future, to a successful future of making sure kiddos get the right level of care for their symptoms, and also that we preserve as many resources as possible in this resource desert that we all live in. So very exciting. I am excited to present about where we are on PeriPan. Next slide. So if you take a look at this slide, you will see in February that we continue to jump up in this upper left-hand corner, that we continue to see increases. There was a decrease in December around the holidays, maybe less people going to appointments, but that we continue to have a steady increase in our call volumes. We're really excited about that, and have seen our highest call volume yet. We also, when we look at, we see increases in those clinicians who have called once. We also are seeing a steady, increase in those clinicians who have called multiple times. So that is our goal, right? And at some point, we may be far into the future, I'm not sure when, but at some point I would hope that the called only once will start to go down as we have more and more people who are calling multiple times and the program isn't brand new to them. But we are still in our rev up phase. We are statewide about 6 months now. And so a little over 6 months. And so we are excited to continue to engage our frontline clinicians and have them calling us for the very first time. It's always exciting to get that first phone call from a clinician and talk to them about what PeriPan can do to support them in the care of their patients' mental health in the pregnant postpartum periods. The majority of our calls are about a specific patient, about 83%, if you can see in this bottom left-hand corner. And then about 2/3 are requesting some type of referral resource, and 45% are asking about a medication-related issue. And so both of those can happen simultaneously. And just as a reminder to all of us, we have one-on-one meetings and lots of meetings with our team across CPAN and PeriPan, but for all listening, these access projects are really focused on building capacity in that frontline clinician. So yes, we are trying to get the patient they're calling about to the appropriate resource and get them some help, but the actual goal of the research of the access project is to build the capacity of that frontline clinician. So in getting that patient to the right resource, in getting that patient, some guidance in that medication management or other therapeutic management, we are doing a teaching, an all teach kind of all learn together with that frontline clinician. So we're building capacity. So those things can happen simultaneously. And research from other access projects shows us that the just providing a referral and no discussion about that patient or where they should go or what's going on does not build the frontline capacity of the clinician. So we want that to happen. We want to help support and connecting with referrals and resources in our community, but we want that to be a secondary thing that happens in this interaction. That the primary goal of the interaction is a clinician to clinician discussion about what's going on, and really sometimes answering that direct question, but thinking about what are the other associated questions, so we can do a mini, and I mean like 2, 3, 4, 5 minute learning discussion about really addressing those frontline clinicians' needs and teaching them a little bit beyond what they called for. So we see we're having those calls and a lot of medication change recommendations. And then we are referring to psychiatry as well. We have direct consults launched, so direct patient consults, where if the question from that clinician is so complex, we're not exactly sure how to answer that without a clarified diagnosis, or if a consult would really help that clinician feel more comfortable continuing that care in their office, then PeriPan can provide that statewide. And we have various different HRIs providing those direct consults, and other HRIs can transfer it to have that direct consult done. And in that research that I was referring to before for access projects, we say the referral really builds capacity, not the clinician to clinician discussion builds capacity quite intensely. And then additionally, that direct patient consult experience for the clinician is the thing that builds capacity the most. It's the item when you look back, or the area of the access project that has the biggest bang for its buck in helping those clinicians feel like someone has clarified this diagnosis, they've seen this patient, they've laid eyes on this patient, they've guided me in what to do, and so I feel more confident about these next steps and what to do in the future. So we want to make sure we're providing those across the state, and we are working together, all of our different HRIs working together to make sure when it is appropriate, when it is helpful, that we are providing those direct patient consults. Next slide. So when we look at who is calling, this has been a question in the past, and so we wanted to break that donut down on the last slide into a little bit more specific graph. And I think, we are talking with obstetrician offices and family medicine offices. We're talking with pediatricians when we talk to them about CPAN as well. So I think it's really important to know that our obstetricians, our OB-GYN clinician colleagues are calling primarily, followed by our pediatricians. And then we have residents, and we haven't broken that category out. And so that's one of the things that I think would be very interesting to do. But we have quite a few residents calling us, which is exciting to build that capacity early and to make sure that they're aware as they move on to practice after residency in the state of Texas, that they know this resource exists. So that's a really exciting thing to track and is increasing over time. We have psychiatrists calling us to ask us like, hey, my patient has become pregnant. These are the medications she's on. Is this safe? What should I do next? How should I counsel or guide her? So we appreciate those discussions. And then our family medicine colleagues as well calling us. So these give us opportunities. We see some opportunities to improve our engagement with our family medicine colleagues, who are in some places in the state providing quite a bit of obstetric care, in other places in the state maybe less. But we want to make sure that we are engaging all of our different colleagues working with pregnant and postpartum women to improve their overall well-being, create the best environment for the development of that baby, to hopefully prevent future mental health distress as much as we can in those growing children. Next slide. When we look at PeriPan enrollment activities, so you see the bottom orange line is when we started with our pilot project. So that was in August of 2022. There were 4 areas, 4 HRIs in Texas that started engagement and enrollment. So you see that took off pretty quickly, and then was a slow and steady climb after that. And then when we look at the beginning of September of 2023, it was when we launched statewide statewide. And so you can see another big jump in the enrollment there. So that's really exciting. And then we see back in 2024 and how we are significantly higher and enroll quite a few clinicians across the state of Texas. Of course, we have less clinicians providing obstetric care than we do pediatricians providing and family medicine docs providing well child care. So we expect that number to be lower than our CPAN numbers overall, but we are making steady and significant progress in the enrollment of our obstetric clinicians across the state. And so my eternal thanks to all of our different HRIs who were working together for sure as one team to enroll and engage our clinician colleagues across the state and let them know that PeriPan is available to them statewide as of September 2023. Next slide. So just as a reminder, we have both a webinar, and that's on the next slide, but wait just a second. We have a webinar and an echo series. We have a monthly webinar that happens, well, every month at a general cadence and with topics, and then an echo series in the spring and the fall. The webinars are generally more lecture focused, really slide based, talking about providing education and information, something to listen to, an opportunity to ask questions at the end. They are open to anyone who wants to, any of our clinicians across the state who want to listen in. These can be residents, they can be our therapy colleagues, they can be physicians, nurse practitioners, physician assistants. So any really, and I'm not meaning to leave anybody out. I'm not going to sit here and list every type of different clinician that could participate in this. But our webinars really are for anyone, and there's no obligation to come to every single webinar, but once you register, you'll get information about the next one. The Echo series, as Echoes go, are these Extension for Community Health Outcomes, are a more specific process where we present cases and then discuss them. So more case-based discussion about these different topics, a small didactic session in there, but really focused on case-based discussion. And so those are more team-oriented, all teach, all learn. People have their cameras on. We're really talking about how to improve care across our regions and learning from our colleagues in many different roles to help us say, what's going on in the Valley and how would you address this there? And is there a resource that we can help you with that may come from a different HRI or vice versa? So it's a really great learning community that we have. Next slide. This is our Grand Rounds webinar. I'm probably using those interchangeably in a confusing way, but our next one is April 16th and really focused on suicide risk and safety assessment in the perinatal period. And so we invite everyone to join us during that time. Next slide. And then I just wanted to tell you about some exciting things that are happening right now, in addition with PeriPan. So as we talked about in the last couple of executive committee meetings, and thank you so much to the executive committee for approving our participation with Lifeline for Moms and their PCORI grant. But and I think where we left that was really focused on, we're trying to identify 8 practices across Texas, obstetric practices that meet the criteria and the volume of deliveries to participate in that program with us. The ultimate goal of that relationship is for us to build the expertise within PeriPan to be able to engage obstetric practices well beyond the 8 that will be involved in this PCORI project. But we have engaged our HHSC colleagues and met with the group, the Community for Health Improvement team, who is in charge of rolling out or overseeing the rollout of the AIM bundles in Texas. And we've met with them to really try to help identify practices across the state and varied regions who would meet the criteria for that PCORI grant involvement, which is really exciting to work together at that level and utilize the data that's already been collected at the state level to say what are what are some potential clinics that would be great to identify to start with in this project. We are also almost finalized on our Peri-Pan perinatal mental health toolkit. We took this from Lifeline for Moms toolkit, which was modified from the original McPat for Moms toolkit, and then had a lot of input from our expert clinicians involved in Peri-Pan to revise and input and add to better serve the women in Texas. We are doing an instructional webinar working with Dr. Gail Olson, who is a clinician, an obstetrician clinician at UTMB, but also represents the District 6. I believe it's District 6. It's not on here. I'm sorry if I'm getting that wrong, which Texas is for ACOG. And so Dr. Olson and I will be doing a webinar that is really instructive of what is contained in the toolkit, how to use the toolkit. There are patient-facing materials in the toolkit that a clinician can use. There are clinician-facing tools in the toolkit to improve understanding of perinatal mental health conditions. This will live on the website, on the Peri-Pan website, so that it's easy to access. And so we really want people to know how to use it. I think it's going to be a phenomenal tool. And then, as we talked about before, we're working with Be Well Texas to develop more substance use related resources. And so as we do that and access to substance use care and those resources, we'll add those to the toolkit in the future. Our plan is to release that webinar on World Maternal Mental Health Day, which is May 1st. So we are working on getting that recorded and then out for everybody on May 1st. And then I just wanted to let everybody know that TPS, so Texas Pediatric Society, has developed a postpartum depression work group. And because, as we've talked about before, pediatricians actually have a higher recommendation or more frequent recommendation for screening for postpartum moms than anyone else, because they see them in the well visits in that postpartum period. And so thinking through how pediatricians respond, what are the best practices, what does a pediatrician need to know? And so Peri-Pan is working with TPS to devise some education around that for our pediatricians and child serving clinicians in the state. I think that is our last slide. I'm happy to answer questions.
Thank you, Sarah. I actually have a couple of questions. One is, I thought that schedule of Project Echo topics was absolutely wonderful. I mean, that's spot on, exactly what I think will attract people. The one question I had, I know there was a Project Echo topic related to medical ethics, which I think could be very enticing to providers, provided it's got not just general CME credit, but it's also approved for that it will fulfill the ethics requirement. Do we know that was obtained or would be obtained?
So we may be talking about two different things. So in our Echo, so we have a webinar series that is monthly, and then we have our Echo series, which happens in the fall and the spring. And then we have another presentation that is a part of our enrollment process that does have an ethics credit associated with it. Now, you can give it outside of the enrollment process, but the goal of giving it as a part of the enrollment process is to really make sure that as we're enrolling clinicians, they know why we're doing this project, what the needs are, and how you use it. What is an access project? How do you use that project? So that is, we do refer to it often as our ethics presentation. It does have ethics certification. It can be given. I've given it many, many times, but it's not typically a part of that webinar or Echo series. Those are more clinically focused. But this is a presentation that's given as a part of the enrollment process to say, hey, here are the dire straits we're in when we're talking about access to care for both kids and women with mental health distress. So it's a combined CPAN, Peri-Pan presentation. And then here's what the state of Texas has invested in order for us to work together so that we can meet these needs. And then here's how you do it. Here's what an access project is. Here's how you call. Here's what happens when you call. And so that's what's really in that ethics presentation. Is that what you're referring to, Dr. Newport?
It is. Thanks so much. And then the other question, the slide you had that showed the specialties of those calling in for consultations, the one group that I missed on that slide, but they may be folded into those, are the nurse practitioners who I know from work with network in another state and PSI. Nurse practitioners, are responsible for pretty high volume of calls. Were they folded into the OB, psychiatry, and so forth groups, or have we not really enrolled many nurse practitioners?
Well, and so when we were enrolled, in Texas, there has to be a supervisory relationship between the nurse practitioner and a physician, which is not the same in every state. And so as we enroll them, we do typically link them with their supervising clinician. Now, I'm sure, I'm going to say this and try to watch Laurel's head, but I'm sure we can break that data down if that's something that you want to see reflected separately.
Yes, we do know NPs do enroll, and we do know that they call. I think partly the reason why she's sharing that number is that our charge for PeriPen was how many OBs we enroll and how many OBs call, but certainly we can start adding, and the NPs. We also have people calling on behalf of the doctors sometimes to get things rolling. So I think that's why this data set is just specifically looking at physicians.
Thank you. Any other discussion, questions?
Before we move on, as people think about their other questions, or don't have any, I did mean to highlight when we talk about, and I think I've said this before, but it's so very important for me to point out that in all of this education that we're delivering, the webinars, the Echo series, all of these things, that there has been engagement from all of our different HRIs to both develop this content, refine this content, and deliver this content. So it truly is a statewide project. When you look at all of the information, all of those different topics, and the amount of content that's been developed for PeriPan and being delivered, that is a collaborative effort across all of our HRIs working together. It's just such a pleasure to be involved in all of this knowledge building. So again, I'm grateful to you and thank you for all of the input that you've provided and that your teams have provided to make this a very successful educational mission by PeriPan.
Dr. Newport, it's 19% of our calls cumulatively come from nurse practitioners for PeriPan.
Thank you. Thank you so much. That was quick. Laurel, you're never cease to impress. So next item on the agenda is the presentation regarding COSH. And I think, Laurel, you're on board for that.
Oh. Before lunch? I'll have your attention before lunch? Okay, we'll see. I'm really getting hungry, so hopefully I won't race through it. Okay, so it was National Pie Month in February and March, and also it's spring fever and all those fun things. But there's actually a song where you can learn the first 100 digits of pi. So if ever you're just bored and you want to learn something, you can just Google that and learn to sing the first 100 digits of pi. Next slide. Next slide. So speaking to similar to Dr. Wakefield, CPEN as well had its best month ever in February of 2024 with 1378 consultations. When you look at that versus how we were this time last year with 1096, it's a pretty nice uptick. So we're very excited for that. We've continued to enroll providers both for CPEN and PeriPan. So we continue to see our providers numbers they've been stabilized, but they do creep up largely because of the work that we're doing for PeriPan and the number of clinics. We are going to be embarking probably on the next biennium, sort of a process where we kind of review the list and sort of make sure it's quote unquote the most up to date with active providers across the state. But again, Texas is big, so any project we undertake related that will still also be a pretty large one as well. And we are, of course, hitting our metric with the callback within 30 minutes. Now, reminding our team that, again, we will definitely work to get that callback within 30 minutes if the provider wants, but we also have a pretty popular process where physicians can say, well, I don't want to be called back in 30 minutes. Could you call me back at 2? And then, yes, our physicians, our team will call them back at the time that's convenient to them. And the other thing that we wanted to point out is that we have something in Texas, because we're so big, we actually span more than one time zone. And so we did just recently work with our great El Paso team to sort of help us. And so we kind of keep the process for the calls going because of the mountain time. So we have a little bit of calls where we get to capture them, even if it's past 5 somewhere else in Texas, because the El Paso team kind of keeps their line open for the mountain time. So we really are doing a phenomenal job in getting our calls back with within the time frame that the physician is asking for, or the NP is asking for, to Dr. DuPont's point. Next slide. So one of the things that Dr. Wakefield kind of pointed to that I want to sort of just keep highlighting again is we really are trying to learn from all the other access programs across the country, and including our consultation with Lifeline. And one of the things that we really have noticed is that we really need to be paying attention to not just the total volume of consults, but also how often are child or perinatal psychiatrists involved in the consultation. Certainly that kind of plays into sort of what Dr. Wakefield already said, is that we know that what is more likely to really move the needle in being a primary care physician, be more comfortable, more knowledgeable, and then ultimately provide more care as appropriate for them to do in their office, is when they actually speak to the psychiatrist, whether it's perinatal or child, and not only speak to them, but also do we have the opportunity to provide a direct consultation. So we've been starting to provide that information to each HRI across the state every month, so we all can be kind of seeing that. But as you see here, the total volume of consults, between January and February, obviously it went up, which we're excited about. That next 1% consults that include a psychiatrist is really about that idea that we want to make sure that as much as possible, our psychiatrists are being involved in the consultation. It's always a both and. We certainly will help them with every resources they're wanting, including maybe trying to find a psychiatrist, but at the same time, sometimes they don't know what they don't know until they speak to one of the psychiatrists. So having a physician or a clinician to clinician conversation around sort of that aspect of care, we really want to be paying attention to that. So we're pleased to sort of see that we're starting to see some increased percentage of time that our psychiatrists are being involved in the overall consultations. The third little one is this total referrals requested. This is when a pediatrician or a family medicine or OB or anybody who's calling us says, could you please find me a child psychiatrist? So again, as I said, it's both and. We're certainly going to not tell them no, we're not going to find you. We will help find them a child psychiatrist. But what we're trying to say is that we really want to have, if they're asking for us to find them a psychiatrist, speaking of the idea that we have a desert across the state of Texas, there's like only 2 counties, according to ACAP, in our state that actually have enough child psychiatrists. So again, because finding a child psychiatrist and finding a perinatal psychiatrist can be exceedingly difficult, and it's not always the best care. Sometimes they really do need to be seen and continue to be seen within primary care. We want to have an opportunity for our child psychiatrist to have a conversation when the PCP is saying, hey, can you find me a child psychiatrist? So we're never going to not give them a referral, but we want to see if we can get more of our psychiatrists to have conversations. So that's why we're looking at, this sort of how many times did we help them find a referral for a child psychiatrist? And then that next one where it says percent CPAN cap involved. This is not our CPAN cap psychiatrist getting a referral to their own team where they'll see the kid. That's not what this means at all. This is how often in that consultation is our psychiatrist being activated to talk to the PCP. And this is where we want to see that number go up. We want to see more of the time when that pediatrician has asked for a CAP referral that we say, sure, we'll get your referral, Dr. Wakefield, but also Dr. Williams would love to chat with you about the case. When would be a good time for Dr. Williams to talk to you? This is what that means here, percent CAP involved. So we're very pleased to see a pretty significant uptick in how often across our state, our teams are getting the child psychiatrist to be involved in that consultation. And then the below one, to Dr. Wakefield's point about what really makes an access program work the best as far as increasing capacity for primary care and the direct consults, we're very pleased to see that we're also starting to see some steady increases month to month with the number of direct consultations that we're providing across the state for CPAN. So that's just a better, I think I didn't explain it as well last time, so I just wanted to make sure I spent some good time on this slide explaining what each of these little data points mean. Next slide. And so we do want to talk about the QI project. So what we've launched as of March was a process where our physicians across the state for CPAN primarily are now in part of, they've always been part of the team, but we really are explicitly asking for them to do some calls to physicians across the state within their hub to try to help increase engagement with those providers. So we, Edith did an amazing job getting all this information all pulled together. We work with Melanie and Lainey and all the teams across the state to really make sure that we sort of created this QI project in such a way that really supported each of the teams and also supported the physicians who were going to be asked to make these phone calls. And I joke a lot of times when I tell the teams, like, I want you to make 800 friends. So what we're really saying is that we want for a physician-to-physician conversation to ensue. Back to that idea of direct consultation. Let's keep going back to that. Physicians learn what we've learned, how they're trained is see one, do one, teach one. They're really engaged in this process of talking to another physician to help them kind of navigate. And so we're really just saying we're going to extending that out to that process of getting providers to be aware of the service and then potentially learn more about the service than what they currently learn. Because we're finding that a lot of physicians are enrolled but are not aware they're enrolled, and they're not aware of all the services that can be provided within CPAN PeriPAN. So this is what we're doing with this particular project, is we're making sort of a very targeted outreach calls to providers that have been enrolled in the service but have not yet used the service. And so I'm really pleased to say we started this March 1st and we've already had 562 calls put out. So what that means, Dr. Lakey, is that our physicians have called 562 other physicians and potentially left a message saying, hey, I'm Dr. Williams from Baylor College of Medicine. If you have a few moments, this isn't urgent. Could you please give us a call back? And those are that's the 562. Of those 562, we've already had 8 of those calls result in the physician calling back and a CPAN consult happening in that phone conversation, which we're very excited about. 20 times where a consult didn't happen, but our CPAN provider was able to provide education directly to that primary care physician about CPAN and what it entails. And very pleased that 3 of them, to Dr. Newpoint's point, were very excited by the opportunity to have an ethics presentation. And so it also resulted in having 3 ethics presentation requests for us. So we see this as an aspect that's adding to our already pretty sophisticated process of outreach, where we have social media, we have email, we have TSAP, ACOG, TFAP, large organizations kind of doing that in addition to the teams themselves with their newsletters and our outreach going directly to clinics. This is a piece of that work. It's not to take away from all that. We think all those things together are really what we need to be doing. So just within the first 2 weeks, including 1 week that included spring break, we've already seen some results from the calls. The goal will be to continue to do outreach, so it's not a one and done. So let's say you had a list of 400 doctors, then if you got through all 400 in the end of 1 month, then you start calling again for the providers who have not yet called you back. We're very respectful of the clinicians' time as well as their team time. We're never asking for anybody to step out of their room, out of their busy day. We're simply asking for us to leave a message, letting them know that we're available and we'd like to speak with them at a time that's convenient to them. So we also anticipate a lot of people won't call us back, and that'll be fine too. But I thought that was really exciting that very, very quickly into the process, we started to get some actual physicians to call back and have conversations. Next slide. I really wanted to highlight, back to Dr. Wakefield's point around direct consultations and sort of how it's an engine for access programs, that our Texas Tech University Health Science Center, El Paso, has really done an amazing job from the get-go when it comes to the direct consultation. They did have a presentation to the CPAN leadership last week, kind of talking through what they feel has kind of helped them be successful. But we really thought it was so important to sort of talk about that we just wanted to give that sort of brief shout out to them. So to date, cumulatively, they have recommended a direct consultation a significant amount of time. And within those recommended, 328 of them have been scheduled. 213 have been completed. And again, within that 328 are some people that they're still trying to kind of reach out to, rescheduling. So, you know, those numbers are never going to be one-to-one. This is clinical care. And so people don't show up, people reschedule. But we are very pleased to see this number kind of be as significant as it is, and they really have a really nice process that we're hoping for other teams to kind of incorporate into their team structure as well. And the other thing that the El Paso team is doing, that I don't have the data yet, and hopefully once they get completed with the project, they're going to maybe come and share it, definitely with the CPEN leadership team and maybe even to the executive committee. But to Sarah's point earlier about the residents calling, we're really excited that we want for residents to learn how to use an access program while they're in training. And so the El Paso team really did a very deliberate process with the pediatric residency program in El Paso, kind of helping the pediatric residency program with education, didactics, as well as helping them kind of have physicians, residents who are kind of held accountable to utilizing the service. And that they're seeing some really great responses from the residents within pediatrics and also the attendings within pediatrics. So we find this to be on the sort of the cusp of some really wonderful things that we want to potentially share with all the other teams and have an opportunity with not just pediatric residencies, but family and OB as well, because we do think this is really important that we teach physicians, even in their training, how to use access programs. And the final thing is that the ACGME, which is the national body that accredits programs across the country, they've just done some upgrades to the ACGME pediatric residency requirements. And one of the things that they're doing is requiring that pediatric residencies actually do more to help those physicians learn how to manage mental health. We actually think that access programs are well poised to assist residency programs in that way. And so I think this project is going to teach us a lot. And I'll be excited to tell you guys more, or even have their project lead come in the future when sort of they have that project all wrapped up. So just something else that's pretty exciting that's happening across the state. Next slide. We also are continuing to work on our educational resources. As you know, we've already completed eating disorders as well as psychosis, and now we are tackling a big topic of anxiety. So we are collecting the resources that all the HRIs currently are utilizing. This includes resources that they give to PCPs, they give to parents, they give to children based on their age. Resources can be handouts, books, chapters, articles, websites, all the things that are resources. We are collecting and organizing them. And then we're going to be asking for experts across the state in the topic of anxiety under these select subheadings to really kind of peruse and look at what resources we've collected, maybe help us retire some that are not as up to date, as well as if we've missed some really great ones, make sure we add them. So that way across the state, whenever we're asked to help a provider with this particular topic, we are making sure we're giving the most informative, up-to-date information based on the topic, as well as the audience that we can for our providers across the state. So this is a big topic, but once we get that one done, we'll be moving on to a next topic. So we're going to get through all the topics within as quickly as we can. Sometimes we have a little trouble with HRIs getting sometimes the executive committee members to respond back who are your experts in various topics. So if you would please, if you're getting a request from either one of your own team members or somebody from COSH to help us find an expert in a topic in your region, in your HRI, please let us know. Obviously, it can be both physicians, psychologists, other team members that have really maybe made a career in knowing about these particular topics. So we're not limiting ourselves to only physicians when it comes to finding experts in the field. Next slide. We are continuing to work with Trade with our data collection system. We have the direct patient consultation process in design, calling on behalf of the doctor, also in design. And as well as having the idea for providers to be able to put a consult in either during the day or after hours through a web portal. And then we also are working on adding unique identifiers such as the NPI that will allow us to capture not just the physicians more clearly, but also to Dr. Newport's point, NPs, for example, or PAs, because currently right now we enroll NPs, but because we don't have a clean database about how many NPs are doing potentially, let's say, pediatrics versus something else, it's a little bit hard. It's a little messy from a data perspective. So we're hoping that NPI might help with that. And that was a recommendation by the internal evaluation and external evaluation team, I think. And also the PCP experience engagement surveys, perhaps having them be within a trait so that they could automatically go out after, you know, identified first-time caller, or they call the third time, or whatever, that the surveys would go out in an automated fashion. Right now, that's something that the teams have to directly do with a person. As far as the person selecting it to go out, they don't talk to the PCP. It's still a survey. Next slide. So moving on to T-Chat, T-Chat referrals. I know you saw this data earlier with Rachel, and again, this slide here is just a clear continuing representation of sort of how we're continuing to grow. And so this referral, this is just the referrals from the last 3 years, month to month. Again, you continue to see that seasonality to the referrals and also to the sessions, but the uptick is pretty substantial. Next slide. Again, we take a gander at this. It's not necessarily shifting that much. We still continue to have, again, people can multi-select. They can have more than one reason for making a referral from a school, but the top sort of problems or issues continue to be anxiety and depression. I would say that, to Dr. Storch's point, the step care, unified protocol are well designed to help with anxiety, depression, as well as mild sort of oppositional defiant behaviors. And so again, because this is a big part of the kinds of reasons where we get referrals, I think it's sort of a nice fit to Dr. Storch's earlier presentation. We do continue still to have youth that are having concerns around, that the staff at a school are having concerns around suicide as well as trauma. And so I think that as we continue to work on different protocols, particularly for that T-Chat 2.0 and that sort of concept of intermediate care, or particularly around trauma, we're going to have more to say about that in the future. Next slide. So this is the number of students that have been referred, how many who've been enrolled, and how many who've had at least one encounter. So we do have, again, not all students that referred sign up to have the service. We continue to have many more students referred than get a service, and partly that is because the families, we're not always getting in hold of them, and it's such a critical point for T-Chat. We must speak to a parent or legal guardian, and so I think that's one of the things that we're going to be working on in the future as well. But again, this is sort of just a nice view of the referrals versus enroll versus served for this particular school year. Next slide. So we're often asked, well, what are the reasons for decline? And as you can see here, that we have, you know, a percentage of families that will, when we finally reach them, the family will say, oh, I'm already in the service. I don't need the T-Chat services. That's 21%. Another group of families that will say, oh, actually, I don't think my child actually needs a service. And so then they decline the service. And then there is a percent of kids that will say, or families that will say, I'd rather have an in-person appointment than a virtual appointment, 6%. There was obviously a really big bucket when it comes to other. And this was somewhat on purpose. You know, we weren't sure of all the different reasons for why, so we didn't want to force a selection. So we have been looking through the other category to see what's within the other category. And what we're noticing is, one, that we want to do some additional training with staff to really help them understand, you know, utilizing, when to utilize other, for lack of a better word, but also that there's possibly a few more categories, that discrete categories that we want to add, so we can be more clear about that. But when you look at the decline other, even within that category, over 54% of the other, which is that 59, are still, we are not able to reach the family. So there's still a significant sort of difference between a referral made by a school to being able to reach and communicate with the family about the service. But then when you look in that 59% category, another 10% of them will say, oh, sorry, I don't need the service, or I don't want the service. And another 7% will say that they need some other kind of care, that T-Chats, that's because we're not in person, we're not providing a crisis service. So we will see this number change and get better as we make some upgrades to the data management system. Will be happening with the new academic year. Just want to give you a snapshot, because there's many reasons for why a family potentially may choose to decline the service, and that's always their choice. Next slide. And just a point that I think we've made, several times, but it bears repeating. The vast majority of care that TCHAT is providing is a psychotherapy. For many children, the first line intervention for a mental health concern is a psychotherapy. And so, we want to make sure that we are continuing to provide that the care that's evidence-based and most appropriate for the reason for the referral. And so again, our teams are more often providing a psychotherapy, and our psychiatrists and NPs provide some assistance as appropriate and needed and with the family's agreement and involvement, but is still significantly less than our provision of psychotherapy. Next slide. We're continuing to work with our HRIs as they kind of manage their onboarding of new districts, as districts start to refer more and more kids, to make sure that we can continue to be able to meet the needs of kids, as we talked about earlier, quickly, but not emergently. And so when we have HRIs that maybe are starting to get a little farther out than we would want them to, and they would want to, we have successfully been able to have other HRIs who have some capacity step in, so that way the family can still get a service as quickly as possible. We are working to refine the case management and care coordination process, and as needed site visits to help with streamlining, improving workflow, and just identifying what we're going to need to have both procedure and policy wise, but also staffing wise, as we start to think through what TCHAT 2.0 means for all those teams. So that way your TCHAT teams can come to you as executive committee and say, here's what we really think we're going to need from sort of a staffing and budgetary perspective for that next biennium. Next slide. And again, we had a massive work groups this fall where we looked at the referral processing process as well as the end of care and the dashboard. So all of those work groups concluded with all the necessary reviews of internal evaluation, data governments, the UT system teams. They're now in trade and working, and the goal is to have all of these improvements ready for the next academic year to start us off. So the goal is to have these ready mid-July so we can train our own staff on them as needed, train any school staff, and then be able to have the new processes for ourselves for the new academic year. And I think that might be the last slide. It is. There you go. Questions? You're like, I'm hungry. I don't have any questions.
Very good, Laurel. Again, congratulations to everyone for the big lift to get this in place. It's encouraging to see the month over month and year over year growth. So thanks for both CPAN and TCHAT. Looking at kind of the time right now, I think it'd be best if we just kind of pushed forward. We just have a couple of short presentations. I think if people need to take a quick comfort break, please do so. Please get back very quickly. But if you guys are okay, we would like to just kind of press through the next two, which I think are relatively short presentations. And that way we can give everyone back some time. Okay. So Jeffrey, let me turn it back over to you.
So are we going to take 5 minutes for a comfort break?
Would you like 5 minutes for a comfort break?
I would.
All right, let's do 5 minutes for a comfort break. Okay. And at 12:10, we will resume, okay? I think I may have been a little stingy on the amount of time for the comfort break, so we may need to wait just a little bit. Sorry. Some people's bathrooms were much closer than other people's bathrooms.
And the knee is different.
I would ask that if you return from the comfort break, if you would turn on your camera so that I know that you're present, because I have to do this mental tabulation here to make sure that we're at quorum. Jeffrey, I think I count a quorum of, I definitely have a quorum now. So why don't we go ahead and begin again? I'll let you call us back to order.
Okay, calling the meeting back to order. And next item on our agenda is the Texas A&M Health Science Center presentation on the TChat implementation. I believe Dr. Watson is going to get us started.
Thank you. Can you all hear me adequately?
Yes.
Thank you. Yes, we're going to be talking about TChat. I have asked Carly McCord to give this presentation. Dr. McCord is the project director for our TChat program. She's a licensed psychologist. She's the executive director of the Texas A&M Telehealth Institute here at the Health Science Center. She's also a clinical associate professor in both the School of Medicine's Department of Psychiatry and Behavioral Sciences, as well as the School of Education, Department of Educational Psychology. Dr. McCord's got a proven record of being able to deliver long distance care through telepsychiatry. And so she just seems fitting to be the one to talk about what we've been up to. So Dr. McCord, I'm handing it off to you.
Thank you so much. Howdy, everyone. Thank you so much for the opportunity to share our work with the Texas A&M TChat program. I'm really proud of our team and the work that they do, from designing workflows and trainings to serving kids to pitching in on some of the publications that I've sprinkled in here. They really are a phenomenal team. And don't worry, the papers are mostly conceptual and descriptive, and no TCHAP patients were recruited for the research. So next slide, I'll be sharing some of our implementation details, particularly surrounding training. And training in telehealth is particularly important to me. That photo in the top right is me as a baby doc, first year student working on our first telehealth pilot project at A&M. And I can confidently say that having had exposure to that type of training is what led to me being a licensed psychologist here in Texas and committing my career to getting care to rural and underserved communities via telehealth. So I've had the privilege of doing this work for the last 15 years using this academic community partnership model, because we believe that our communities have capacity and expertise that together with our capacity and expertise are the best way to keep these services sustainable for reducing health disparities. So having the opportunity to direct the TCHAP project has been a highlight for my career. We've built a network of behavioral health access points in 7 counties in the Brazos Valley. And in this model, we always included the school counselors and the schools and the organizing partners piece. So it was pretty incredible to get to go reach back out to them and let them know that we are going to bring services directly to the schools. It was always a hurdle to get kids from the school to the community access point. Our 4 p.m. slots were always full. So TCHAT has been just an incredible way to get more kids in care. We're committed to try to get in every district in our 19 counties. Next slide. So, but we kept the heartbeat of training as central to the design and implementation of our TCHAP program. Back in 2020, we published this consolidated model that you'll see in the corner. We took all of the available telepsychology guidelines, there's a few of them, and then we identified the overlapping elements and defined these core practice domains of telehealth that we weave throughout our program. One of the things that we wrote about was that each practice domain has to be interpreted through the lens of the setting and the type of technology used. And so TCHAT has helped us kind of unpack each of those boxes of those practice domains. What does it look like in the schools? Trait pushes us, the video conferencing to schools pushes us, and we've learned a lot. And on this slide, you'll also see some of our other core training elements. I think it's important to note that many of these are happening across all of our staff. This is from program coordinators to the clinicians. So this is not just clinician training. All staff have an opportunity for community engagement and participating in outreach from time to time. We heavily emphasize the importance of collaborative care, and I'll talk a little bit about that in a second in another vein. And we have invested strongly in supporting bilingual staffing to serve our Spanish-speaking individuals and making sure that all staff are comfortable using the language line when it's not Spanish. One of the things I'm particularly proud of is our investment in our telehealth platform and that it is bilingual for English and Spanish. So our Spanish speakers, from the first phone call to the paperwork they see to the platform that they log into, it's all happening in the language that they can understand. So we also have a core set of telehealth trainings. One of the ones that we do kind of a deep dive in is the handling emergencies from a distance and making sure that all staff understand and are prepared to manage any crises and de-escalate. And a lot of that ties back to good policies, obviously, and managing risk and doing telehealth. I think that's it for that slide. Another unique component of our TCHAT model includes our use of telesupervision, which we do in a couple ways. First, weekly supervision typically occurs via video conferencing, either with staff that are licensed, but also with contracted telesupervisors. Since we have so many trainees, that allows us to make sure that no supervisor has too many trainees. It allows us to make really intentional supervision pairings too, with specific needs in mind, like pairing bilingual trainees with bilingual supervisors. You can see another piece that I love about our program is how integrated Microsoft Teams is and how important that is for our trainees. They can message their supervisors in real time for, that could be a quick clarifying question on a policy, that could be advice, that could be hop into my session. So it's almost like the transition of bug in the ear to all virtual care. And those messages, if you use Teams, are happening seamlessly. Sometimes they don't even need to respond. They just pop up, get their answer, keep driving on with the session. So you can read more about that in that first paper down at the bottom. Next slide. This is about some of the other ways that we strive to maximize productivity and collaboration. So our care coordinators are set up to reduce burden on the school counselors and on our clinicians. So they're making the initial contacts, they're gathering all the consent forms and pre-assessments. They're taking care of all of the details that get the kids in front of the screen so that clinicians can focus on the clinical work. And also do a phenomenal job with the exiting out into transitioning to other care. We've also invested years in thinking about how to create space for telepractice that maximizes efficiency and square footage, but that counselors don't feel like they're in a box, even though they are in a box. So they don't feel like they're in a coffin. Let's put it that way. But and that we want to foster collaboration. So what we found by using this booth model that you can see the photos of on the side is that it does drive collaboration. We use those for clinical care and for sessions for the privacy that's needed. And then we encourage documenting and consultation and kind of the open office work area. And we see that that really is working more than when folks are tucked away in individual offices. So just wanted to share that. And then last two slides, I'll go over the different pathways for our psychology doctoral students and our master's level clinicians. So we've budgeted for 20 graduate assistants to be assigned across, we've divided our region into 5 zones. So A&M has 3 American Psychological Association accredited programs, clinical counseling in school. We work with doctoral students from all of those programs, as well as from University of Houston and Sam Houston. And we've seen tremendous benefits for their training and future trajectories. And the pathway is working. We have a handful of previous students that have trained with us that now are on staff as clinicians and psychologists. And my final slide is for our LPC training pathway. You can see our partners on both sides, and you can kind of see how we step up the number of clients on their caseload and then step down the amount of training and oversight that they receive. And that concludes my presentation. Does anyone have questions? Thank you, Alan. Yes.
No questions, but again, thank you for presenting and thank you for the work. I think it'd be good for us to figure out how we maybe better capture some of the trainees that are embedded. I think we have our hands around that a little bit, but maybe we need to do that a little bit more because it's a nice story that people are being trained and then ending up working in these programs. I think that's a story we need to tell the legislature.
And I know we're not the only ones, so
yeah.
Do we want to let Sarah ask her question?
Yep. Go ahead, Sarah.
Sure. This may not be something that you could tell me offhand, but I really love this idea of and we have developed a unit where we're working towards like more shared workspaces to improve collaboration, and then shared clinical spaces where we like rotate in and out. And so it sounds like you're doing the same thing in this virtual platform as well. which is not something that I conceptualized in the same way. And so I'm wondering if you have a ratio in mind, like how you know, when you're thinking of this many clinicians and this shared work area, how many of the cubicles, or not cubicles, but the sliding glass doors do you need for each area? And this may be something offline too to get at later, but
Yeah, I'm happy to dig in with you. Yeah, we built a calculator for, you know, number of hours per week that clinicians should be seeing clients, and then making sure the workspace is available. The logistics of, you know, maximizing those like empty hours is something that we're working on. But I love to talk about that stuff, so I will send you an email.
This is Cheryl. Hi. I think that in itself could be published, because it's something as like being, you know, managing clinic space and having to think about that. It's really tough. And so I don't know, it's kind of cool, because with the telehealth and people sometimes working remotely, how we calculate that, because I know Brittany and I are, you know, we're doing a revamp of space, and every year, you know, you may not, everybody may not know this, but the chairs know this. I mean, people come around and ask, you have to document exactly how much space you have and how it's document how it's being used. So a tool would be wonderful.
So I will follow up with you as well. Thank you.
I guess the other idea I haven't heard of before, maybe others are using it, but that real-time call for help through Teams to get additional consultative services is a nice use of the program, and maybe others are using that, but that seems to be a nice model.
Thank you. Yeah, that paper just came out last week, so check it out.
All right.
Dr. McCord, this is Luann Southern, and just last week I was on a conversation with some folks that were talking about the potential of tele-supervision for individuals who need that supervisory experience post-graduation. And so I will follow up with you about that. I know that Dr. Nancy Trevino from Texas Tech Lubbock was on that same conversation with me. So now that I know that you all are also doing that, I'll rope you into that conversation. Thank you.
Sounds good. Thank you. Have a great day.
Thank you very much. Thank you for your time.
So Dr. Lakey, I assume you want to move on to the next item on the agenda, and that's the presentation from Dr. Harvey regarding the status of the development of the Texas Child Mental Health Strategic Plan.
Yep, that'd be great.
Good afternoon, everyone. I am Courtney Harvey. I serve as the Associate Commissioner for the Health and Human Services Commission's Office of Mental Health Coordination, and also serve as Chair of the Statewide Behavioral Health Strategic Plan. Next slide, please. So I want to be sure that everyone is level set on what the Statewide Behavioral Health Coordinating Council was legislatively directed to do out of the 88th. One of our deliverables is to develop a children's behavioral health strategic plan. I think the rider is titled Children's Mental Health Strategic Plan, and we have gotten several questions from stakeholders about whether or not this is a mental health plan or a behavioral health strategic plan. So I do want to take the time to clarify that this is both a mental health and substance use plan. We are required within the plan to cover descriptions of who provides what services and to which children, strategies to identify and address gaps in care, a discussion of workforce shortages, information on funding and reimbursement, and then children-specific data and expenditure information. So you all might be familiar with the fact that overall, we're talking about the 20+ state agencies, institutions of higher education, and judicial organizations that receive state funds for behavioral health training or services that serve on the statewide behavioral health coordinating council, what we know is that collectively we are allocated by the legislature, this also includes Medicaid and Medicaid match, $12 billion for behavioral health services. But what we do not know is how much of that $12 billion is specific to children's behavioral health services. So we are very excited to be working across the organizations that serve on the statewide behavioral health coordinating council to really kind of get at what is that number that we are actually allocated specific to children's behavioral health. And I'm sure there will be lots of caveats with that figure, just based on how our funding strategies are currently structured. What is a bit different also about this strategic plan is that in years past, when the statewide behavioral health coordinating council has been directed to develop strategic plans, it is the responsibility of the body to develop the strategic plan. This is a bit different because this rider actually requires that the statewide behavioral health coordinating council formulate a subcommittee, and it's the subcommittee's responsibility to develop the plan. Next slide, please. So I won't read this entire list of people or organizations that are represented on the subcommittee, but I'll just say that we do have broad representation to include payers. We have representation from the Behavioral Health Executive Council. We've got people with lived experience, pediatric hospital and other medical associations, judicial representation, policy and training institutes as well, in addition to, of course, providers, specifically state hospitals, local authorities, FQHCs, children's hospitals, and then private psychiatric hospitals as well. Next slide. So some of the data gathering activities that have been underway is, of course, conducting literature reviews. There's been a depth of research and articles published on children's behavioral health to include gaps and solutions to address those gaps. We've got public data sources that we're looking into. We had a presentation series where we asked for local authorities as well as FQHCs, residential treatment centers, as well as some of the state agencies that are core to providing behavioral health services to children to come and actually present on their array of children's behavioral health services, which has been, I think, very insightful. And then concurrently, we are also planning some youth focus groups to hear from those individuals that have been involved in the juvenile justice system, that have been involved in the child welfare system, to hear directly from them what they believe could have helped them as they were navigating those systems and could help them even to date. And one of the things that we should have done up front is done a better job about how to incorporate youth with lived experience onto the subcommittee. We invited some youth with lived experience onto the subcommittee, and they said, look, we've got jobs, we're trying to find housing, we're trying to hold down our employment, et cetera. We don't really have time to spend 3 hours a month in this meeting. And in addition, the conversation seemed very much above our head. And I was thinking to myself, well, to be fair, for a lot of us who have been doing this for years, parts of the conversation might be above our heads. So we received their feedback, and that's part of why we decided that we needed to do some youth focus groups concurrently in isolation with them. Other initiatives that are happening that we are very excited about, that we believe are going to inform some of the recommendations that are included in the strategic plan, include a children's behavioral health policy lab. This is an opportunity that is hosted by Health Management Associates, the Annie E. Casey Foundation, Casey Family Programs, the National Association of State Mental Health Program Directors, the National Association of Medicaid Directors, Child Welfare League of America, and they put together this children's behavioral health policy lab with the idea that they would bring selected states together to come up with sort of a strategic plan focused on building out the children's behavioral health service array, as well as looking at governance and financing structures. So Texas did apply for that in the fall, and we're one of 8 states selected, along with Georgia, Kansas, Kentucky, Maryland, Missouri, Missouri, Pennsylvania, Utah, and Wisconsin. So if people are curious about how that initiative is progressing, I'm happy to provide you all with additional information. The state team is comprised of myself, Luann, we've got Trina Ita with the Department of Family and Protective Services, Julie Wayman at the Texas Education Agency, Dr. Evan Norton at the Texas Juvenile Justice Department, as well as Casey Cardwell, who is our Medicaid representative. We also intend for the strategic plan to be informed by the study on mental health services for children and adolescents. It's being conducted by Texas A&M University. The Department of Family and Protective Services Behavioral Health Strategy, that is a new office under the Department of Family and Protective Services that is headed by Trina Ita. And then we are also offline concurrently consulting with Meadows Mental Health Policy Institute, as well as the Hogg Foundation for Mental Health, which both organizations have been extremely helpful to us to date. Next slide. So the real work is beginning now. So I would say in the fall, we really spent time trying to kind of level set everyone serving on the subcommittee about the state of affairs. What is the landscape in terms of children's behavioral health? And that included, like I mentioned earlier, the presentation series. We really wanted to nail down what our mission and vision and guiding principles were going to be for the plan. One of the models that we decided to use as a framework for the strategic plan is the system of care, which many of you may be familiar with. It's a national philosophy that's been around for decades, but also maps to a state requirement that HHSC partner with several other state agencies to advance systems of care locally. So beyond it being just kind of this national philosophy around how we create ecosystems of care for children who have serious emotional disturbances, which is the language they use. It also is about how do we build local boards and governance such that you have a structure locally that is intimately familiar with the landscape of needs for children and families, and then can elevate those conversations to that statewide infrastructure. So that really was the focus for us in the fall. And then going into the spring, between now and May, we've broken our subcommittee into a work group. So we've got the 5 that you see here, one that is focused on governance, metrics and outcomes, service array financing, and navigating access to care, workforce, and then a youth and family voice. So our last meeting, which took place last week, was the first time that these work groups actually had an opportunity to meet and start to begin to discuss some concepts that they might want to further flesh out into recommendations that will be presented to the full subcommittee for discussion about which of those we will want to highlight in the strategic plan. Next slide. So this is our timeline. I mentioned March through May. Right now, we're working on developing goals and recommendations in relation to governance, funding, and the service array. We are hoping that we can complete a draft of the plan between June and July. So concurrent to the work that we are doing now within our work groups, we have Dr. Christopher Greeley, as well as Lillian Nguyen, who is in the Office of Mental Health Coordination at HHSC, who are going to be the subcommittee's ghostwriters. And then August through November is when we plan to submit that draft for further review and approvals. We do plan to reach out to certain organizations to give them an opportunity for a review. So if the consortium is interested in that, please do let us know. And again, the goal is that we would have this submitted to the Legislative Budget Board in the governor's office by December 1st. Next slide. And if you have additional questions about the strategic plan, this is my email address. Please feel free to contact me, and then I'll take any questions that you have now.
Very good. Thank you very much for being here and for the presentation and the work on the strategic plan. Any questions or comments?
This is Luann, and I've been involved in the development of this work. And why this is so important for all of us is that the consortium plays a key role in terms of the service delivery system for children with mental health needs and their families here in Texas. And so what I know that we even had some conversations earlier about access to care and some of the services that we know are evidence-based, some of the services that we know are needed for children. For example, when they complete TCHAT and they need a referral to a specialized service in the community, the plan is really a way to look at that bigger picture, the broader view of what is available now, where we might need to grow some things that appear to be working very well, and where we need some new things in place in the state across all of the big financiers and providers of care for Texas. And so I'm also, if ever any of y'all want to ask about what's happening, I'm happy to also serve in that capacity. I know that Dr. Nancy Trevino, who many of you may know, who's at Texas Tech, has also been involved in a lot of this work as well. And I think she might be on the data group, if I'm not mistaken.
That's right, Luann.
Yeah, so she's also a really good point person to talk to about that. And so happy to be a point. This is very exciting. Almost every meeting we go to, somebody talks about this plan. So I know there's a lot of buzz about it and a lot of excitement about it.
Yeah, I will just say the other thing that makes me very excited about this plan is that I have never had the opportunity to participate in writing a strategic plan that is paired with a placeholder exceptional item for implementation of the plan. And so that is something that I believe to date, the agency being the Health and Human Services Commission, I believe intends to have a placeholder exceptional item for this strategic plan. And I know it's been engaged in conversations with the Department of Family and Protective Services and maybe other state agencies about potentially partnering to put forth a collective request for children's behavioral health carried by these organizations. So that's, I think it's a very exciting time. Dr. Wakefield?
Hi, Dr. Harvey. Nice
Hello.
to see you. Super exciting. I am a huge fan of this plan. And I was listening to the people involved in it. And I was just wondering if you felt like, because it sounded like there were a lot of administrators and a lot of people with previous clinical experience. But I didn't know if you felt like you had enough or were seeking like current frontline clinicians who are providing the service, and if that was another maybe, focus group or something else that we could either support or just recommend or something like that. I think this work is so difficult, and another focus of a strategic plan, I hope is also about workforce retention and how important it is to try to keep our clinicians doing this work after we've started it.
Yeah, that's a really great question. So there is obviously heavy participation from associations, and some of those individuals are practicing clinicians. But I think we never want to miss an opportunity to hear from more. So I would love to hear your thoughts on that. The workforce retention piece is going to be huge. I know the writer was very vague, right? And said, talk about workforce shortages. It's like, oh, we don't just want to talk about workforce shortages. How are we, recruiting and retaining people? My joke internally is, how do we get people like to believe in altruism again and, wanting to help thy neighbor when they can make millions of dollars doing something people want it quick and fast. And so one of the things that me and Luann have talked about is, things like telesupervision. Could we start up pilot a hub where we allow people to get supervision hours at no cost? Or could we pay for internships and externship stipends? Some of these things HHSC is actually piloting using community mental health services block grant funds, which is why I want to talk to the folks about the telesupervision hub piece from Texas A&M. But yes, that recruitment and retention piece is really important. Loan repayment programs, all of those things. We've pretty much said to the workforce work group, you may not need to reinvent the wheel, right? There's lots of papers that have been published with really great strategies from a recruitment and retention perspective that we really just want to leverage that could be low-hanging fruit this session. So I want to connect with you offline to hear more about maybe an additional focus group with people who are on the ground, really tethered to this work day to day. Yeah. Dr. Trivedi.
This is exciting, and thank you for doing this. I think one plea is in the process of developing this plan, somehow incorporating like measurements of outcome.
Yes.
We often in behavioral health, mental health, get a lot more attention to amount of services rather than just outcomes. And so anything that you can highlight would be wonderful to include.
Yeah, I think that's a really great point. And one of the reasons that we wanted to have a metrics and outcomes work group, and we've got people like Marcia Ori and Nancy Trevino and others who have elected to participate, Molly Lopez, who I see is on this call, serving on that work group, because we think that's very important. I think people really struggle with a collective narrative regarding what we are buying and outcomes associated with what we are buying for that $12.1 billion that is being allocated to behavioral health. What is that collective story about how we are progressing, recovery and other kind of health outcomes for children and families? And I think we could do a better job of telling that story. I don't have the research brain per se. I understand data, but I'm looking to people like you all who are used to being in this world every day to really help us kind of advance. How are we going to collect information to help us tell that story? And then what does the output look like in terms of transparency and continual publications around how we are implementing this plan and the outcomes associated with it.
When I'm going to jump back in, but Dr. Trivedi, I want to amplify what you said and maybe clarify or expand on it, that what I wonder too, Dr. Trivedi, when you said that, was about, recommendations or a part of a plan that anything that's rolled out, if we could have a focus on utilizing measurement-based care in addition to the stepped care model that you saw, maybe, I don't know if you were on earlier, that Dr. Storch presented, but just the goal in, we know we're providing more medication and more therapy services nationally than we've ever provided before, and our suicide rates are still high. And so some people say, well, then that doesn't work. But what we say is that we're not using measurement-based care to get people to remission. And so we have to use measurement-based care to know that people are getting to remission and that they're benefiting from all these services that we're doing, instead of just getting them a little bit better. And so I think any ability to utilize those things, even as a recommendation, or the stepped care process of not putting someone in such an intense service that's mismatched with their current symptom level, so that they are overwhelmed by the intensity of the service and they drop out, right? Or
they refuse it.
Right, they refuse it. Or the mismatch where they have high symptoms and they're getting an inappropriately low level of intervention. And so using assessment and measurement-based care to really match people with the appropriate level of care, and then to see if they're getting better, so that we can step them up or down that care. As you've heard today, I feel like that must be a part of our strategic plan across Texas.
Agreed. And I don't know what people's capacity is, but we're still taking people on the work group. We intend for there to be interim work group meetings beyond the monthly meetings that we're having as a full subcommittee, though our full subcommittees will be additional opportunities for work groups to convene. So if people are interested in serving or want to down assign that to someone, please let me know. We need your brains on that work group.
We will be, I am speaking for Dr. Wakefield, but she and I would be happy to help.
Excellent. Thank you. All right, last call for questions. Not seeing any.
Courtney, I guess the one question I have that I'm trying to think through is that kind of process wise. And so you're developing the strategic plan, a variety of entities will be potentially asked to do new things. You have an exceptional item for HHSC. is your thought that all those collectively would be in that exceptional item, and then dollars would be farmed out to other entities that are not HHSC as part of that? Or will you be working with those entities related to that plan so that they will incorporate potential ask in their budget request independently of that exceptional item? Does that make sense?
Yeah, it does make sense. I believe at this stage it's the latter, Dr. Lakey, as far as coordinating with those other organizations to see if they would be willing to carry forward some of the recommendations that are highlighted in the plan. So the Statewide Behavioral Health Coordinating Council within the last month has begun to have what we are calling joint exceptional item statutory initiative meetings. So this is our opportunity to convene, start to think about exceptional item concepts that our agencies are right now conversant about, though there's not been any hard decisions about what people would want to carry forward. But what we have said to members of the Children's Behavioral Health Strategic Plan Subcommittee is submit all of your ideas, through this process, but that we would be sure to carry forth those ideas to some of the other organizations serving on the coordinating council for their respective leaders' conversation and decision.
Right. Well, thank you very much, Dr. Harvey, for all the work that you're doing on this. And again, I know Luann is very much embedded in the process. And so thank you for that and incorporating kind of our thought process in it. And again, I think you heard probably a willingness from a variety of folks here that if they can be helpful, would love to provide some additional input.
Thank you all so very much, Dr. Trivedi, Dr. Wakefield. I'll be in touch.
All right. Very good. Any other questions? Before we close, Jeffrey, if I may, wanted to make sure people saw that email that was sent out earlier today from Luann and the team. We have a new member of our team. And it's going to take me a little bit to pronounce this name. It's not doesn't roll off my tongue yet. But Alex Valhi Dimitriopoulos. Alex, I butchered that, but I apologize. She is a new member of our team, is taking the financial role for our group. She will be sending folks a template related to the budget requests. And so want to make sure that is a name that you will be looking out for. And, as we've noted before, it's time for us to start doing the work to develop the budget for the next legislative session. That I think plays into a lot of the things that we've talked about today. And so again, would ask that get your attention to make sure that we have time to refine those numbers, understand the numbers, think with you kind of what is doable and how do we move forward for the next legislative session. So again, would ask you to take a look at that email and look forward to additional emails coming from Alex. Does that make sense to everybody? The other thing, we've decided to not have a meeting in April. Our folks will be working with you to gather the budget information, and then the meeting following that in May, we'll be able to share that information with you. So a lot of work will be taking place across the consortium, but again, want to be respectful to your time and want to make sure that people have time to concentrate on that, looking internally related to what your needs will be for the budget, and we'll have conversations with each of you to make sure we fully understand that over the next several months. Luann, is there anything that I'm missing?
No, you were spot on.
All right. Well, surprise. Every now and then I may get the messages correct. With that, then I think we are done. And so, Jeffrey, I need you to officially close us since I'm not in that room. And we'll look forward to working with everyone over the next several months as we, again, iron out the request for the budget for the next biennium.
Well, thank you, Dr. Leckey, for entrusting me with the car keys today. So do I hear a motion to adjourn the meeting?
So moved.
Do I hear a second?
Second.
All in favor, say aye.
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 All opposed, say nay. And the motion to adjourn is approved.